let's begin with the basics. And the clinician often encounter myocardial dysfunction in sepsis, but the terminology can be confusing. So first, would you define septic cardiomyopathy? How would you define septic cardiomyopathy in the clinical context?
Right, and that is an excellent question, and even experts do not completely agree. So, number one, I'm not confident yet that I would call it a septic cardiomyopathy, because I'm not confident that there is any actual disease in the cardiac muscle. We do know that there are changes in the hearts of patients, as well as in experimental data. In the actual cardiomyocyte, we know that myocardial shortening is reduced. So perhaps there is a cardiomyopathy, but we do not see the sorts of changes that we see in other types of cardiomyopathies. So let me just say that there is definitely changes associated with sepsis. I would call it a sepsis-induced myocardial dysfunction at this stage. I would be hesitant to call it a septic cardiomyopathy until we have more data. And at the bedside, I still think that echocardiography is the most useful clinical parameter, because you can actually see changes in contractility. You can see if there are any regional differences that will suggest an acute coronary syndrome, which you would need to exclude before you would make a diagnosis of sepsis-induced myocardial dysfunction. You can exclude things like hypovolemia. So if you have a very hyperkinetic left ventricular ejection fraction, which can actually be included in your diagnosis of sepsis-induced myocardial dysfunction. Number one, you need to exclude hypovolemia, right? Because otherwise you can't make that diagnosis. All of those things, valvulopathies, I think you need to, one needs to do your echocardiography, exclude all the other diagnoses before you make a diagnosis of sepsis-induced cardiomyopathy. And one more thing that I did not mention in my lecture is these patients come to us in extremis. When they come to ICU, they are, in profound shock. They have high doses of vasopressors and inotropes. Yeah. And that in itself can also induce a stress cardiomyopathy with contraction band necrosis and all of those things. So all of these things get mixed up.
So how do you differentiate someone who is on the high vasopressors? How would you differentiate whether it's a really sepsis or it's a septic cardiomyopathy in those situations? It's just an echo, or you have some other parameters also to look into?
Yeah, they're very, very difficult. So the important thing is you need to exclude hypovolemia, valvulopathies, and all of those things. And then what I usually do is, if you think that there is a stress-induced cardiomyopathy or Takotsubo-like syndrome, and especially if there is LVOT obstruction, then I try to turn down the dose of inotropes.
Okay. And see what
and see what happens, because then that makes the differentiation between whether it's completely stress-induced or whether it's just sepsis-induced. And of course it goes hand in hand, because sepsis is also a stress. And this is why it makes it so incredibly difficult to define an entity that is just sepsis-induced myocardial dysfunction.
Especially in case of hypovolemia, RV dysfunction, or the septic shock. I mean, it's very difficult to differentiate. So is there any red flag pattern on echo that should immediately tells you, this is something, this is not purely a septic shock, vasopresia, this is a cardiomyopathy, and will alter the management immediately?
Well, I mean, regional wall motion abnormalities, that's number one, because we know that our patient population is increasingly cardiovascularly comorbid, and a lot of these patients will have a type 1 myocardial infarction that we just simply don't know about, right? And a lot of our patients are intubated, sedated, they do, the signs and symptoms are, we can't tell whether it's related to the sepsis or whether it's related to acute coronary. So regional wall motion abnormality is certainly a red flag. But beyond that, very, very difficult.
So anything beyond echo, any biomarkers, maybe troponins or the BNP play a major role in your practice? Do you use it? Do they have the diagnostic significance, or only the prognostic markers are there?
Yeah, so interestingly, troponin is a prognostic marker in critically ill patients, and it is a prognostic marker in sepsis. But beyond that, we can't say anything. There is no causality. It just indicates some sort of form of badness. Now, if we accept that sepsis-induced myocardial dysfunction does some sort of damage to the heart, then you would expect the troponin to rise. And indeed, it does. So in our series of patients with septic shock, we see that troponin increases that fulfill the fourth universal definition of myocardial infarction. They all, 80% have acute myocardial injury. So that's incredibly non-specific when you have 80. Yeah.
It's just a prognostic marker with the levels going up serially. Maybe it tells you patient is not going to do well, or maybe the initially high levels would tell you the prognosis is going to be the worst.
Exactly.